welcome to our show. This is the School of Acute Medicine. We have, as you know, we started a journey about 2 weeks back with the purpose of disseminating knowledge on acute medicine among the doctors of Bangladesh. So, as part of our journey, we are organizing regular webinars and releasing regular educational resource materials from our page. Currently, we are on Facebook. So do follow us on Facebook. Like the page is called School of Acute Medicine. This is a joint endeavor of Access Medical School and Academic Forum for Acute Care Physicians. So today we're lucky to have two distinguished guests with us. We have Dr. Suneel Galipothu, who is an emergency medicine registrar. He is an ST4 registrar in emergency medicine at Northampton General Hospital. And we also have Dr. Ahmed Shams, who is the senior house officer of the intensive care unit of United Hospitals Limited. So again, welcome to our show. So the topic today we will be kind of having a broad discussion is we will be talking about the magical world of ABCDE. Yeah. So the reason we have started this our journey with this particular clinical topic is, as a doctor, I personally feel that if the way in which ABC management is carried out is probably the defining factor in the patient's survival when they come to a hospital in the first 24 to 48 hours. So in my opinion, often it is not the specialist management which keeps the patient alive or saves the patient from dying. It is that doctor, usually a junior doctor, who receives the patient in a hospital and then carries out the initial ABCD assessment and management. In my opinion, if that is carried out in a proper way, the patient then, you buy time for the patient so that more specialist and more expert management can be set in. But the initial 24 to 48 hours where the patient is resuscitated through an ABCD measure is probably what plays the most defining role in creating the difference between life and death. So anyways, we will be talking about this topic over the next 1.5 hours to 2 hours. So we will probably start with Dr. Suneel's opinion regarding overall ABCD management. Dr. Suneel, would you share your opinion on why ABCD management you think is very important?
Hey, thanks, Latif. Hi, everyone. Just before I start, just want to let you guys know that I'm just coming from my night shift, so I might not sound very sober, and I might just skip some things or something. But even before that, I apologize if things go wrong from my end. But I'll try to be as awake as possible. And thanks, Latif, for this opportunity. So yeah, as you mentioned earlier, ABCDE, definitely that's what that's what improves the patient's survival from the time they arrive to hospital, or even from the pre-hospital in our field. If you talk about emergency medicine, I think the ALS and BLS, this is what I think everyone talks about, how to get your things right. Don't worry about your end diagnosis. It can be any simple diagnosis to very complicated, fancy diagnosis. But when you come to this, the initial few minutes or to few hours of resuscitation is what keeps the patient alive until they get your definitive treatment that we can leave for specialists or your senior colleagues. But the ABCD doesn't change for most of the diagnosis. That's what I've seen from even in your cases that you have made in your PowerPoint. And it's a very good topic for the beginners. Yeah. I think you are muted. Latif, you are muted. Latif, you are muted, I think, Latif.
Can you hear me?
Yeah, now I can hear you.
Dr. Shams, would you like to share with us why your opinion about ABCDE management, Dr. Ahmed Shams? I think we have momentarily lost connection with Dr. Shams, so we will
Okay.
wait for Dr. Shams to come back to us, but we will probably start with a case regarding, we will over the next 1.5 hours discuss a few cases. So it's also useful for all those guests who are with us here to kind of, if they want to ask any questions, please do ask questions through the chat box. So this is about a case one, a 40-year-old man he's found unconscious in his home. Yeah. So not much is known about him, apart from the fact that he has a background history of lung cancer with bone metastasis, and he's currently undergoing palliative treatment. So he's brought to the emergency department. The emergency department doctors see him, and it is noted that his respiratory rate is quite low at 8. His oxygen saturations are normal. His blood pressure is slightly lowish at 90/60. He's slightly bradyc. His heart rate is just about normal at 60 per minute. It is regular on ECG. He has a blood sugar of 5.7. A neurological examination is carried out, and it's shown that he doesn't have any asymmetry in his neurology, but his pupils are pinpoint. He has a GCS of 5 and is noted to have a temperature of 98 Fahrenheit. So if I ask you, Suneel, what is it about this patient what is it that first crosses your mind when you see a patient like this?
So Latif, what I was going to do is, I thought if Dr. Shams was around, I thought for 1 or 2 cases, I was going to be that, the overzealous junior doctor who is focusing on the end diagnosis.
Mm-hmm.
And then you guys could have corrected me that how you focus on, how you can actually work upon, because I would talk about, I want to do urgently, I want to move him to a CT scan. I'm thinking about a stroke, or it could be a bleed, or it could be metastasis.
Yeah, no, interesting. So
yeah, I would have been that person, and then you guys could have been, no, this person, what is wrong here? How can you even move him to a CT scan? How will you even get, is he even fit to go to a CT scan at this point? So I thought that way will be a more interactive session.
Yeah, that's quite interesting. So why don't you, Suneel, tell us what you would do if you were an overzealous doctor focusing on the end diagnosis?
That's what so I've been, if they come and the paramedics tells me this, I'm happy. Oh, there is a good saturation there, and everything nothing seems to be very worrying for me. Oh, there is pinpoint pupils and the low GCS. So I want an urgent CT scan on him. I think he have a brain mets, or whether he has some brain mets which could be starting to bleed, or he developed intracranial hemorrhage. So I want an urgent CT scan on him. I would call a CT room and tell him that I'm bringing this patient.
Okay, and now let's imagine that you are that sensible senior doctor who's discussing with that particular doctor. So what's your opinion then?
Yes. So first of all, I'm not happy with his the respirator. So we are starting to begin with the moment I hear the whole story from the beginning. So I'm just worried about his airway at this point, because his GCS is low. He isn't ventilating very well. His respiratory rate is quite low. So even his saturation is fine there. I'm not happy about his A and B at this point.
Yeah.
And so I would like to actually assess, make sure I'm happy with my airway and find out why there is no ventilation at this point.
Yeah.
So then move on after that. So if somebody is breathing at 8 per minute, that means obviously it is a ventilation issue. Oxygenation seems to be okay. No one has mentioned about secretions or airway not being patent. Is oxygen seems to be okay. One of the clues that it could be an impending airway, but not at this point. I think airway is still patent. I'm assuming because I don't
Yeah.
have the full information.
Yeah.
So B is the main issue. So first of all, you want me to tell the concerns or actually do the whole management on this patient?
Okay.
Intubate.
If you just tell me what your concerns are.
Yeah. So first thing is the respiratory rate.
Yeah.
And next thing is blood pressure is 90/60 for a 40-year-old man, which isn't a very good number.
Yeah.
Heart rate is 60, but we don't know exactly if something else is doing that or
Mm-hmm.
if that's his usual, whether he was an athletic or he is on beta blockers or whatever it is.
Yeah.
But it is regular. I'm hoping that there is an ECG. Usually paramedics do bring that when they bring the patient.
Yeah.
And blood glucose seems to be okay,
Yeah.
but the pupils here are pinpoint with the low GCS.
Yeah.
So yeah, this will be one more concern, which will be at the yeah.
Exactly. So to me, Sunil, the beauty of ABCDE management is it not only ensures that the patient is kept safe from the immediate threats to life, but
Yeah.
systematic ABCD management also makes sure we reach the correct diagnosis as well. Because basically, if somebody's doing ABCD correctly, then they make you go through all the measures that helps you reach a correct diagnosis. So if everybody can see this screen, I'm just going to go through a few things which everyone should do when dealing with an emergency assessment. Yeah. So this is the ABCD here. So in airway, it's not only about checking whether the patient already has a threatened airway or not, but it also is about deciding whether there is a risk that in the next few minutes or hours, the patient can lose his or her airway. So it's looking for active signs of airway compromise, but also looking signs which suggest that there may be airway compromise in the hours that follow. So I think a look at the GCS is very important. If the GCS is really low, we should be planning ahead before airway compromise can occur. And then it's also about correcting once you realize that airway is compromised. So if somebody has got tongue fallback, you put an oropharyngeal or if it's not contraindicated, a nasopharyngeal airway. If somebody and then it's about recognizing the features which suggest that there is airway compromise. For example, stridor, upper airway transmitted sounds, lack of air entry, and obviously one of the most important things which happen when somebody loses their airway is their oxygen saturation falls. So if the oxygen saturation is normal, at least till then the airway is okay. That doesn't necessarily mean that the airway will be okay in the next few hours, but at that very moment, probably the airway is okay. So one of the earliest signs which happens if somebody loses their airway is oxygen saturation start to fall. And other basic measures like, putting them in a propped up position, then the head up chin lift maneuver, if it's not contraindicated, can also help open up the airway. But one of the important things a clinician should decide is if the GCS is really low, and if they think the GCS is too low for the airway to be safe, they need to decide whether they can correct the GCS quite quickly, or if it's going to be a more long-lasting issue, in which case does the patient need and is the patient appropriate for an intubation and mechanical ventilation. Does that make sense, Sunil? Do you agree with this?
100%. Yeah. So
Yeah,
that's what I was mentioning about the impending airway loss, which you have presented is an excellent way of looking what can happen in the next, and is the patient appropriate. I think securing the airway is the first thing to before considering anything else for this.
exactly. And Dr. Ahmed Shams, do we have you here?
Yes, hello. I'm really sorry. My connect. Can anyone hear me?
Yeah, don't worry. I know there is some difficulties with the connections at your end. So we are grateful that we have you back. Yeah.
Yeah,
So
yeah.
we were kind of discussing a patient who has a background history of active lung cancer. He's currently on palliative treatment, found in his hospital, collapsed. He was brought in and he was found to have a really low GCS, and he had a low blood pressure, he had pinpoint pupils, and he had a low heart rate and a low GCS and a normal temperature. So we were talking about how an overzealous doctor Just focusing on the diagnosis would try to rush the patient to a CT, thinking, oh, pupils are pinpoint, it may be a hemorrhage, or maybe trying to do something else, like focusing on the diagnosis. But we were talking about how a more sensible doctor would first focus on the ABCDE. And one of the things we were already worried about, the fact that even though this patient's airway seems to be okay because the oxygen saturations are all right and there is no stridor or anything, but a GCS of 5 means that there's a risk of impending airway obstruction. So apart from airway, is there any other thing which worries you about this patient, either Suneel or Shams, apart from the airway?
Yeah, I can see the respiratory rate. It's 8. It's very less.
Exactly. Yeah. So what is it that worries you when somebody's respiratory rate is 8?
It worries me that probably there is some respiratory depression, maybe some problem in the brainstem. So there can be some impending respiratory arrest.
Exactly.
So we have to secure the airway.
Exactly. So I think the next step, once we are satisfied with the airway, is looking at the breathing, isn't it? When we talk about breathing, there are 2 questions we must ask. One is the state of oxygenation of the patient, and what do we do about that? And B, what is the state of ventilation of the patient, and what do we do about that? So breathing is not only about checking the lungs and looking at the oxygen saturation and checking the respiratory rate and giving oxygen as needed, but breathing is also about deciding whether there is any impending chance of respiratory arrest, in which case we should be taking urgent measures, or we can be facing death in the next few minutes. So this is particularly important, I feel, in patients with a low GCS. So in somebody who has low GCS, if there's any worry about an impending respiratory arrest, then we should be really, really worried. And if the patient is for intubation, we should urgently discuss with the critical care department regarding what's the next step. Do you agree, Suneel?
Yeah.
And what is it about a respiratory rate that makes you worried that there may be chance of, like if you look at somebody's breathing, what are the things which will make you worried that there may be impending respiratory arrest?
So as Shams mentioned, is the hypoventilation, which can, so obviously you're not clearing your CO2, which is going to worsen your GCS further, get more drowsy. And eventually the type 2 can become into type 1 once you stop ventilating properly.
Yeah.
Yeah. So,
and also sometimes what makes me worried is the fact that when somebody has apart from a low respiratory rate, when somebody has an irregular respiratory pattern, that also worries me quite a lot. When the irregular types of breathing comes in, there's a lot of names given to them: apneustic breathing, stroke breathing.
Strokes, yeah.
But even sometimes somebody like, that day I saw a patient who had hepatic encephalopathy grade 4, and she was not for intubation, unfortunately, because of the comorbidities and the underlying condition. And she was having a very high respiratory rate with normal oxygen and with normal blood gas. So my worry was, with such a deep coma, when she's starting to be tachypneic at about 30 breaths per minute, probably this will suggest central neurogenic hyperventilation. So it's about recognizing the fact that this patient's respiratory rate or pattern does not look right. So if that patient was for intubation, then probably we would have had to discuss with the critical care department quite rapidly regarding what do you want to do next, because there is a risk of impending respiratory arrest. So yeah, so I think that's like case number 1 did teach us quite a lot. The blood pressure is quite low as well. So what we probably need to do is, in C, we probably need to get a cannula in and take some urgent bloods.
Yeah.
And maybe start the C will tell us whether the patient is already overloaded or not. And if the patient is not overloaded, we need to give some fluid challenges.
Yes, exactly.
Yeah, we will be talking about fluid challenges in a bit, but we just need to realize that a 90 by 60 millimeter mercury blood pressure in somebody who is not fluid overloaded might suggest this, obviously suggest this would need some management. In terms of D, What are the things that you normally check in D? What are the things that like you're interested in?
Yeah, you written some GCS in there already.
Yeah.
And
Uh-oh.
sometimes this outflow.
Yeah. I'll just,
So the outflow is, sorry.
yeah, sorry, something happened to the screen. I'm sorry. Yeah. Okay, great.
Yeah, but so the thing about pupils comes in disability sometimes, or
Yeah.
most, yeah, pupils, and in general, if they have, you know, in trauma, it just slightly different, but
Mhm.
I think these three will be the major and disability.
Yeah. Shams, do you want to add anything? Is there anything else you would do in D or?
Yeah, usually in D, what I tend to do is like I do gross neurological assessment. That is like
Mhm.
starting from the head, I check the meningeal the rigidity, the signs of meningism.
Yeah.
Then I check the pupils, any
Yeah.
unequal pupils or pupil constriction, and if any cranial nerve pulses grossly. And then I check any focal neurological defect, like any site, any hemipharesis, or any, and then I check the plantar. The plantar, I check it, and then before doing all that, I try to assess the GCS. This is
No.
what I usually do. Like in disability, I usually tend to check the neurological signs plus the meningeal, any sign of meningism.
Exactly. So I think in D, it's important to make sure the patient does not have any focal neurology, because that would suggest a possible brain lesion, isn't it? If somebody is like presents in an unconscious or an altered consciousness state, it's either a metabolic problem or a brain related problem. So after initially stabilizing the patient in terms of airway, breathing, and circulation, the next question we need to answer is, do we focus on rushing the patient to a brain imaging, looking for intracranial space-occupying lesions or any other structural lesions, or a stroke or a hemorrhage, or whether it sounds like a more metabolic problem which is leading to the low GCS, or a hypoxia related problem, and all these things. So I think one of the important features to look for in a neurological assessment is whether there is any focal asymmetry, which would mean we need to prioritize towards looking at the brain itself. Yeah. Uh, in focal asymmetry, I usually look for whether there's any gross difference in the way the two sides are moving, the two arms or the two, the two upper limbs or the two lower limbs. Is there any difference in the way they're moving? I look at the plantar examination. I look at the pupils. Is there any asymmetry in the size? I look at the eyeball. Sometimes if you just look at the eyeballs and they're not conjugate, like they're not looking in the same direction, this may point towards an probable brain like lesion. And obviously, once that is not the case, the other reason why somebody may be having altered consciousness or low consciousness state may be an underlying meningism. So I think it's very important to check for meningism. One of the other things I usually do in D is I also look at the blood sugar glucose as well. So, this is something I've just kind of practice myself. Otherwise it's sometimes like you end up quickly forgetting about the blood glucose, which is so important in any patient, not only presenting as unconscious, any patient presenting with any acute ABCDE disorder. Like if somebody's having arrhythmia, you need to check the blood sugar. If somebody is having seizures, you need to check blood sugar. So I usually practice the blood glucose levels in D so that I don't end up forgetting after that. So yeah, so having looked at D, I think I've just put it in the screen. So I look at the capillary blood glucose, any lateralizing signs, what are the pupils, what are the plantars, any obvious cranial nerve palsy, is there any obvious facial deviation, and then a formal recording of GCS and meningism. And in very selected cases, only after ABCD is done, I normally, if there's still a worry, I would probably go back and do a fundoscopy. So I think GCS is something which I found a bit tricky because, Suneel, I don't know whether you'll agree with me. GCS is something which we traditionally have practiced doing, but it's more useful in head trauma patients or neurosurgical patients rather than medical patients who may have an altered consciousness level, in which case I've not found the GCS quite useful. Is that something you would agree as an emergency physician, Sunil?
Yeah. GCS was validated only in trauma patients, and it's because we didn't had anything that's very commonly used, and everyone is familiar with that. We started using GCS, but ideally should be only used in trauma device.
Exactly. Yeah. So I've not found GCS very useful in, say, a patient who presents with hepatic encephalopathy, or a elderly patient who just presents with a delirium, or it's more about, the overall daily subjective feeling of how alert they are, how oriented they are. Sometimes we use scores like AMT4, what's their age, or whether they can recognize people around them. I think it's like, in my opinion, GCS is not very useful. It's more about the subjective daily improvement or deterioration in the patient's alertness and orientation. One of the things which is important with ABCDE management is, when you look at sorry, I'm just bringing it up again. Yeah, when you look at A and you pick up a problem, ABCDE management and assessment is not only about assessing, but it's also about managing. So if you pick up a problem in A, you don't go on to B before you've corrected what you've picked up in A. If you've picked up something in B, you don't move on to C before you correct that. If there's hypoxia, you need to correct that. And then so that's why you need to go serially. Is that something you would disagree or agree with, Shams?
So I completely agree with you. That's what we tend to do as well. Like usually, if we find any abnormality in A or B or C, like we correct that, then reassess, and then we move on. Like until and unless we correct each of the steps.
Yeah, but obviously sometimes
Okay.
you've got a
Yeah.
big team. Yeah, Suneel. Yeah, sorry.
Just sorry to break you.
Hmm.
So that's how traditionally it is taught, that you need to intervene. But
Yeah,
once you intervene, you need to again go from A. Don't continue where you are left, because if you even do an intervention in B, that's how the ALS is traditionally taught.
yeah.
Even if you intervene in B, don't go to C after your B intervention. You need to start from A again. What that B change has made to your A.
Oh,
But
that's very useful. Yeah, that makes sense. Because, for example, if somebody is unconscious due to hypoxia and I've corrected the hypoxia, the airway may have changed, isn't it?
yes,
Or yeah,
that's how it is taught. But just so that in practicality, even as a instructor, what happens is, how they teach it is, sometimes you say, like, how this patient, we are not happy with the A there. Is low GCS in your whole case. When you read that, he's hypoventilating. Unfortunately, you won't intervene at that point immediately, so you are not going to intubate. You are not going to do anything in the A for this patient. For example, I'm telling this patient. So you will say, kind of, so I'm not very happy at this point. I'm just going to do like a prop up and things like that. But somehow we tend to go to B, saying that I'm not happy, but this could be an impending airway, but I'm going to continue my assessment, but I'll keep that in my mind.
yeah, true. I think the practicality is very important, and I'm glad that you brought it up. The practicality. Sometimes I think especially with ABCD, it's very important that you don't manage the patient alone. You, in any patient who needs very severe and close ABCDE management, it is important to work in a team where there are plenty of members, so that different people can do different things. Somebody needs to lead, but different people can do different things. So, for example, you may still be dealing with a hypoxia, but one of your team members can quickly move to C and get a cannula and bloods.
Yep.
Yeah. So you don't necessarily have to wait till you're dealing with the hypoxia. If you have another team member who is already putting a cannula and a blood in. So I think if you have a large team of 4 or 5 members looking after the same patient, and that is exactly what should happen in an emergency. If somebody's impendingly, like, has got an impending life-threatening condition, a lot of them can actually happen together. But for the leader who's leading the team, it's important to have a good clarity of mind regarding the progression of things. So while somebody is sorting out the airway, somebody can at the same time look at the oxygen saturation and correct it.
Hello.
Somebody at the same time can put some bloods,
Hello.
put a cannula and take some bloods. Somebody at the same time can do a bedside ECG. And if you have another member, they can easily look at the pupils and the blood sugar. So all these things can happen together. But I think for the leader, it's important to have context, like idea of context regarding how things are moving. Yeah. Okay, so that was an interesting case. I learned quite a lot. But ABCD management wise, I think the ultimate diagnosis, which the overzealous doctor was interested in at the very beginning, is there may be either a brainstem event, which is causing cardiorespiratory imbalance, or there may be, there may be, the most likely is if somebody's on palliative care, has morphine, there may be an opioid overdose, which again can cause cardiorespiratory depression. A pinpoint pupil would also point towards an opioid overdose. So I think in this sort of case, when the airway is the GCS is so low that you're worried about impending airway obstruction, I was having it, like I was referring it earlier, that do you intubate the patient, or do you see that whether the low GCS is reversible, which means the GCS can quickly be improved, in which case you just need to protect the airway by basic measures like keeping the patient in a propped up position, suctioning of any airway secretion if they are there, and the GCS should return to normal by itself. So in this sort of scenario where the GCS is low due to, say, opioid overdose or hypoglycemia, conditions which are very reversible, you would probably just nurse the patient in the safest way so that they don't lose their airway, like I said, by propping them up, by suctioning their airways, and then treat the reversible condition. In this case, probably you'll give a shot of naloxone and then allow the GCS to recover by itself. But again, an example of how an ABCDE assessment and management has not only led you to the correct diagnosis, but in the time that it took for you to reach that diagnosis, you also made sure that you saved the patient. Because otherwise, if you were too late, the patient may have had a tongue fallback and blocked his airway and died within a minute. Or the patient may have aspirated, and aspiration pneumonia, we can know it can become really, really dangerous. Yeah. Or if the patient's blood pressure drops even further, they may have a circulatory dysfunction, which may quickly impair their brain function and other vital organ functions. No, fair enough. I'll probably just show another case just for an example. Yeah. So this is a 55-year-old man who has presented to the hospital with 3-day history of abdominal pain, which is generalized, and vomiting for 5 to 6 times a day. For the last 1 month, he has been suffering from low-grade fever, night sweats, tiredness, lethargy, and dizziness. On arrival to the hospital, he's found to have a respiratory rate of 24, oxygen saturation of 98% on air, the lungs is clear, the heart rate is 132 per minute, the blood pressure is 75 by 35 millimeter mercury, the capillary refilling time is 5 seconds, he has a GCS of 15 and there's no focal neurology, and the blood sugar is slightly low at 3.5. Abdomen is soft, there is no peritonism, his legs are soft, there is no DVT. He has got generalized blackening of the skin and the mucous membrane. The temperature is slightly low. So to summarize the case, a 55-year-old man who has been having ongoing issues with weakness and lethargy for 1 month comes to you with 3 days of vomiting and abdo pain. Yeah. He's found to be hypotensive, he's tachycardic, he's tachypnic, hypoglycemic, and slightly hypothermic. So again, when we see a patient, what would the overzealous doctor think and what would a sensible doctor think? And Dr. Suneel, you can walk us through the case.
I want to give him IV fluids and get a CT abdomen, please.
Yeah. Sorry?
I want to give him some IV fluids, some dextrose, and get him a CT abdomen.
Okay. Yeah. So CT abdomen, we will like obviously get back to that.
No. I want to do as the overzealous doctor.
Oh, you are the overzealous doctor. Okay. Okay, fair enough. So you want to just give him some IV fluids and get him to rush him to a CT abdomen. Okay, yes. And then what would the sensible doctor do, Dr. Suneel?
So I will assess him that, so we are going to do our ABCD assessment again.
Yeah.
So he's a 55-year-old man. So I think, are we happy with our airway here?
Yeah, we are happy because
that seems to be okay, and he's talking to us presumably, so we are happy.
And his GCS is not low, so he will not lose his airway. Yeah, good.
So I always, I know the SATs are good. The sick people it's okay to give some oxygen. Later you can reduce whatever happens. So I think I'll talk about it later anyway. So under B, you said he's breathing a bit faster, but it could be from many other causes.
Yeah.
So it always helps just to give some oxygen. We can reduce it much later. So that was the reason of my, that was my reasoning. Just give oxygen. If it turns out to be something else like your COPD things, we can change it later. So it doesn't hurt to give oxygen. It's
Yeah,
okay.
I completely agree. But just for the audience, are you worried about the oxygenation because the respiratory rate is so high, or do you think the lungs is not an issue here?
Yes.
Okay, so you think the lungs is not an issue, the oxygen, so you're happy with the oxygenation
No,
at the moment?
he's talking means, so if a person is awake talking, SATs are okay. So we are not worried because if lungs are very, very bad, I think we can find the other signs of it. Okay.
Yeah,
So
exactly. So
I think mostly if you can put the case on the screen once.
yeah, I can do that.
Yes. So we are seeing him tachypnic, but his SATs are okay. But I think obviously this scenario mostly towards points to C in this patient.
Yeah.
So he's having some vomitings, he's losing fluids, his tachycardic, hypotensive, capillary fill is prolonged, and he's hypoglycemic. So this patient, I think if A and B ones, need to jump to C, or if, as you said, if there is a multi-team there, jump to C straight away and get some large bore cannula to give some IV fluids.
Yeah.
Probably some dextrose too on the side, or if he's able to tolerate, just give something orally.
Yeah.
And in our C, we will consider doing some, I mean, at the same time, you send your bloods whenever you're getting your cannula, you
Yeah.
get your blood gas to see whether what's happening to the acid-base status.
Mm-hmm.
That also can be if they develop some CKD, if they develop, AKI, the renal failure, that can explain your tachypnea.
Yeah.
Sometimes if it's acidotic.
Yeah. But you'll take bloods and you'll take a blood gas.
No, I'm saying, yeah, in the C, when we are doing your cannulas, and because that happens simultaneously in the practical life, isn't it?
Absolutely.
Yeah. So in our D, apparently, again, he seemed to be alert. I think GCS is 15, and
Yeah.
there is no focal neurology mentioned. And yeah, temperature is also fine. No obvious neurology. So that is his D.
Yeah.
And E, I think we have generally talked about his blackening of skin and mucous membranes.
Yeah.
And no other obvious rashes or things like that.
Mm-hmm.
So yeah, that will be my A to E for him initially to see
Yeah.
how he responds to our interventions and take it from there.
Fair enough. And Dr. Ahmed Shams, you are a critical care doctor. You work in the intensive care department. Would you like to just take us through what you normally do in C with regards to both assessing and managing a patient? If somebody is hypotensive, say, for example, this patient.
Yeah, somebody is hypertensive, for example, this patient, if I check the vitals, his heart rate is 132 and blood pressure is also less. And
Yeah.
the capillary refill time, it's more than 3 seconds.
So in general, what would you do in assessing and managing a patient with hypertension? What are the points? If you just take us and the audience through, what are the points you would check in C, and what are the things you would do?
We usually check the pulse, blood pressure, and if possible, the postural drop, if possible, if the patient is not that bad.
Yeah.
And then we secure IV cannula, and
Yeah.
we start them with fluid.
Yeah.
If we clinically, if there is no signs of fluid overload clinically, then we immediately start a fluid.
Yeah.
By the fluid challenge.
Yeah.
Around 200 ml of fluid stand running, and
Yeah.
then we reassess the blood pressure after after the fluid is gone, and then we also reassess we give the fluid challenge first, 200 ml. If that doesn't work, we again tend to give another 200 ml bolus fluid stand, and then reassess, and then if needed, we after we give the bolus fluid, and we check if there is any signs of fluid overload. If still it is not corrected, then we tend to we decide with the specialist for giving any ionotropes or not, ionotrope support.
Beautiful. Thank you so much. It was quite elaborative. So maybe I'll use this opportunity to share with you what I do as well. And so normally if I see somebody with a low blood pressure or hypertension or any other circulatory related problem, I go through a checklist of things I'll do for every single patient and then get to take a decision of what I need to do about this particular patient if they have a problem. So this checklist of things that I would normally go through is, I'll just share the screen here so that it's also useful to see. So I'll check the heart rate. I will check in special situations, I'll check the pulse between the two hands. Not always, but in special situations, I can check that. And in special situations, if the patient is able to stand, I'll check a postural hypotension. But this is probably not an emergency till a proper ABCDE assessment has been done. Yeah. I'll check regarding the heart rate. I'll check the rate. I'll check the rhythm as well. And also for the pulse, the nature of the pulse, whether it's high volume or low volume. Yeah. A low volume pulse may often suggest a circulatory dysfunction. The blood pressure, I look at the blood pressure. I also look at the difference between the systolic and the diastolic blood pressure, which can sometimes give a good idea about the pulse pressure, which can be, for example, reduced in conditions like dengue, which can be elevated in conditions like sepsis, early sepsis. Yeah. And in special situations, I would check the blood pressure in both the arms. Not always, but again, in special situations. I look at the peripheries and look at the temperature because I know that shock is often associated with low temperature of the periphery. So the periphery, the hands, the feet, they often become cold and clammy. I look at the capillary refilling time, and I had a senior doctor once teach me that in circulatory dysfunction, the capillary refilling time is often as reliable as a lactate level if you can do it properly. Yeah. So it was quite interesting to hear hear that. I do a quick precordium assessment just to ensure that there is no there's no extra murmur or things which might affect my opinion. I look at the JVP. JVP is very difficult to read, but I think for every doctor as they progress in their career, they should get better and better in JVP. This is very important, something we need to pay a lot more importance than we probably do. I look at quickly at the lungs to see whether there's an evidence of any pulmonary edema. And then I look at their hydration status, whether they're dehydrated or not. So in terms of hydration status, I think it's so important in so many conditions. If somebody has low blood pressure, you need to comment on their hydration status. If somebody has AKI, you need to comment on their hydration status. If somebody has sodium abnormalities, you need to comment on their hydration status. If somebody has potassium abnormalities, you need to comment on their hydration status, isn't it? So I look at their hydration status, and I think for the junior doctors who struggle to kind of who struggle to understand whether somebody's dehydrated or not, my advice will be look at their skin, look at their tongue, look at their urine color, take a history from them. Have they been more thirsty than usual? Yeah, and then use it with with signs which suggest whether they're overloaded or not. So don't just look at somebody's legs and just because you've got pedal edema and say that, oh, this patient is not dehydrated. Or don't just listen to somebody's lungs and end up saying, oh, this patient has got bilateral basal Krebs. This patient is not dehydrated, because the hydration status is a composite marker of a lot of things put together. So somebody may still have pedal edema, still be dehydrated. Yeah. Somebody may still have lung Krebs in their bases, but still be actually dehydrated intravascularly. So it's about putting all the evidence together and then deciding if somebody's dehydrated or not. Yeah. So once I've done, and I would also do a bedside ECG. I would put a cannula if there isn't one. And through the same cannula which I've just put in, I would take some emergency bloods. In an emergency, the bloods we normally end up taking is CBC, CRP, electrolytes, liver function tests, renal function tests, and obviously a blood gas. So a blood gas doesn't have to be an arterial blood gas. If there is no problem with oxygen saturation, if there is no problem with carbon dioxide, then the same blood that you have taken from the cannula can be put through a blood gas analyzer, and this will give you a venous blood gas. And the things we're interested in is a quick sodium level, a quick potassium level, a quick lactate level, which a lot of modern blood gas machines give you. And lactate is quite important because it tells you about the circulatory status of the patient. So once I've put a cannula, once I've taken bloods, then I decide whether the patient has got a low fluid state or an overloaded state. If their blood pressure is low, it does not necessarily mean they have got low fluid state. They may still have high fluid, and the blood pressure may only be low because the cardiac contractility is not enough. Yeah. Or on the other hand, it may be a low fluid state like sepsis, like hypovolemia due to any other cause. But also, because I've done a proper ABC assessment by now, if somebody also has conditions like obstructive shock, say due to a massive PE, this also should become evident. So by the time I've done a complete C, if somebody's hypotensive, I should have a fair bit of idea what's going on. And for somebody who's hypotensive, I know traditionally medical schools have taught us to divide hypotension into, or shock into, obstructive or septic or distributive or hypovolemic shock. For me as an acute physician, I don't know whether Suneel and Shams, you will agree with me. If somebody is hypotensive, for me, the main question is, does this patient benefit from some fluids or not? And why is this patient hypotensive? So instead of dividing into cause, I look for reason, the particular reason why they're hypotensive, because I can then correct it regardless of what the type of shock is. And the main question I want answering is, if I give this patient fluids, will this patient benefit or not? Yeah, this is my way of looking into somebody who has got hypertension. Why hypertension, and will fluids work? Is that something you agree or disagree? Because this is something I've just built for myself.
Yeah, I absolutely agree with you, Raiyan. And we also I also, as you mentioned very nicely, the steps that you follow. And as a procedure as well, we tend to do nowadays. We have started like from the starting of COVID. We tend to also do that bedside echocardiography, as we have discussed previously as well. To measure the diameter of the inferior vena cava as well in some patients, so that whether we can give fluids or not. So we also tend to do that as well in selected patients.
Yeah, I'm glad that you brought this topic up, the bedside ultrasound and bedside echo. Luckily, we have also got Dr. Suneel, who is quite an experienced doctor in terms of bedside ultrasound and bedside echo. In fact, Suneel, you have your own channel for ultrasound and echo, isn't it?
Yeah, I was going because of this ABCDE. We thought we were doing the bedside stuff. We didn't talk about gadgets actually.
Yeah, exactly. Do you want to just quickly, before we move on, do you want to quickly share your screen and show us your page that you run?
Yeah, I will do that, but I just want to add a few things for the fluid assessment part.
Yeah.
So initially what my impression was, when somebody comes to ED, so I think we are looking at two different perspectives here, because I think Shams talking the way how intensive care, and how you're talking about probably in the more of a acute medicine or a general medicine ward, when someone is becoming sick or just admitted and turned into a sick. But what happens in our side of the world is that we know very little about the patient when they actually come in an emergency medicine as such. So sometimes if they're not giving history, so what you have is the little 2 words that the paramedics saying that, oh, we just found a person unconscious on the floor. So you understand that point of how we approach, I think, but at the end, the assessment wise, because certain things that we mentioned, I think even the ALS wise, if you are ACLS, traditionally when you do these courses or how they teach, we don't do so many steps at the point of each of this. Sometimes you won't get a lot of time to actually go through a step-by-step process of it. It's good to have a mental picture that this is how I proceed in my C. So I will check your precordial. I'll make sure, it's very good approach. But I think sometimes depending on how sick the patient is or what is your situation around, sometimes our intervention goes just like that, that you will just give the interventions and see what happens. So hypotensive patient, traditional ALS teaching is that give a 250 bolus. Don't worry about it. Don't worry there, because your pedal edema comes much later in your assessment when you're examining. In your C, the moment you are seeing hypotensive, they just say give some fluids and then see what happens.
Yeah, that's
No,
interesting. That's very interesting. This is
no
something.
one, yes. So what happens is, give fluid bolus. If it is, because it's 250 mils, it's not going to put whatever is the stage of this person. Because in B, I think we all talked about it. In B, we already get a small idea about, how bad the chest is or what it is. And 250 mils is not going to do anything to any patient. Is the traditional how ALS is taught normally.
That's very interesting, Suneel. Yeah.
And just to add some more things of your fluid assessment status, what I learned, and apparently this ITU in Leicester, they like this very much, this passive leg raising test. It substitutes your postural blood pressure, that you make a patient stand up to see the blood pressure drop.
Yeah.
So this passive leg raise test, so literally what happens is you are doing a blood pressure in supine and you're going to raise the bed so that the head is down and the legs are up. Apparently it adds around 500 mils to your circulation. And when you have an arc line, immediately you start seeing the blood pressure swing in there.
Yeah.
You will see change in the swing, and you know this patient is fluid responsive, and you can actually just give fluids. Even if you don't have the arc line, we can actually repeat your blood pressure. So passive leg raise test, and it is safer to do in a patients who are worried about making them stand or making them sit with the legs hanging down to check your postural blood pressure.
No, okay. Yeah, that's really interesting. So I completely agree with you, Suneel. So I'll probably share my own insight into own views about this. So like I said, and obviously the next webinar will actually be on how to manage a patient with hypertension or how to manage the hemodynamically unstable state. That will be a webinar which we are planning for next week. So we can have a lot more discussions about it. But when I'm dealing with a patient who's got low blood pressure, like I told you, I try to answer two questions, only two questions. Why is the blood pressure low? And the second would be, what can I do about it? Yeah. So in terms of why the blood pressure low, the obvious reasons are commonly infection, dehydration, hypovolemia due to any other cause. It can be internal losses. It can be external losses. Losses can be fluid, losses can be blood. Yeah. It can be due to third space losses as well. Or it can be due to things like massive PE or tamponade, or it can be due to a cardiac dysfunction, which can be secondary to either an MI, a massive MI, or a fatal arrhythmia or dangerous arrhythmia. Yeah. So these are the gross reasons why somebody may have low blood pressure. But by the time I finish my C, I should have an answer to most of them. For example, if it's sepsis, I should have known by ABCDE, because in E, I check the temperature. I will have some history maybe in E. If it's due to hypovolemia, if it's due to DK, I will have known by ABCD because I've checked the glucose, I've checked the blood gas. If it's due to hypovolemia due to any other cause, I will have known. If it's due to a massive MI, I should be knowing because I'm doing an ECG. Yeah. If it's due to arrhythmia, I should be knowing. If it's due to PE, again, I should know because if somebody has a very low oxygen saturation, the lungs are clear and the blood pressure is low, I start getting worried. Tamponade, I should have some bit of idea, even without the echo, because the heart sounds may be very muffled, the JVP may be raised. So a good ABCD assessment should tell me why the patient is hypotensive, and I should focus on treating that. Regarding whether the patient will benefit from fluid, that is my second question. I do agree completely with you, Suneel, that a 250 milliliter of fluid is just 1 glass of water. That's it. That's nothing more than that. Regardless of how overloaded the patient is, a 1 glass of water into a 5 liter system will not make any massive difference, either in terms of worsening them. However, it can lead to tremendous benefits. Because the whole idea of the 250, and this is again something I would like to stress with my audience, the whole idea of the 250 ml fluid bolus is not to treat the hypotension. It is for the doctor themselves to understand whether the patient will benefit from fluid or not. That is to answer my second question, will the patient benefit from fluid? So the whole idea is the 250 that you give, something like a normal saline or a Hartmann's, whatever you're giving, you have to give it so rapidly within 2 to 3 minutes to highest 5 minutes that it is going into the system so rapidly that it pushes your baroreceptors. So then you see whether there is an improvement in the patient's fluid status. By improvement, I mean rising blood pressure, falling heart rate, improving capillary refilling time, improving temperature of the peripheries, and all these things. If there is an immediate improvement, you know the patient is fluid responsive, which means the patient will benefit from fluids. If there is no response, it may be one of two things. It may be that the patient cannot take more fluids, or it may be that the patient will benefit from further, might still benefit, but you need to try more challenges. So my concept of fluid challenge is I stand bedside, look at the volume parameters, give 250. After that, I review the volume parameters. If there is no change, I again repeat the same thing and keep on doing it with monitoring the volume parameters in between each boluses till the patient either shows improvement or deterioration. The moment the patient shows deterioration, but the patient is still hypotensive, it suggests a probable cardiac cause. I would probably immediately call the critical care department whether this patient will need inotropes or vasopressors. If the patient shows improvement, then fantastic, because I know that the patient can then get fluids. So I'll keep on giving fluids for the hypertension. However, if I have given 8 fluid boluses, 250, 250, 250, 250 like this, and the patient has still not deteriorated, but did not show any response even after the 8th bolus, that is, I've given around 2 liter fluid, then I'll again call my critical care department to ask them, do you think the patient will benefit from vasopressors or not? This is how usually I go about with the fluid challenge. Is that something you would massively differ, Shams or Suneel?
That's exactly, that was the point I wanted to make, but yeah, you told it more clearly.
Yeah, you said it more clearly.
But I think one of the things I often see is when patients with the hypotension, some doctors just say, oh, give 1 liter over 1 hour. I don't think that's a correct measure because A, you're giving 1 liter without monitoring, because the next time you're going to monitor is after the liter has been given, like this 1 hour later. And B, 1 liter over 1 hour will not serve your purpose because it has not been given rapidly enough to push your baroreceptors. The whole idea, if somebody's sleeping and you're playing a song in the background, they won't wake up. Yeah. But if somebody's sleeping and you suddenly put a loud noise, they will wake up. I think the fluid balance is kind of that thing. Like the whole idea is to give a small but very rapid amount to wake the baroreceptors up. So if somebody gives 1 liter over 1 hour, I don't think that really serves a purpose.
Yeah. Yeah, okay. That's the tradition again. Yeah. Give and reassess. Give small, rapidly reassess. It's the
exactly
mantra.
Great.
I just want to. I'd like to just add one more point, Dr. Latif, that as I work in the COVID ICU, we tend to keep the patients in a negative fluid balance. So I guess that's where like we have a lower threshold, and as I work in the ICU, as Dr. Suneel mentioned, that we have a lower threshold for starting the inotrops. Like we need to keep the patients in negative fluid balance, and also as all the patients are COVID, and at the same time, like we don't go for 8 fluid challenges. Maximum we go for like 200 to 50 ml 4 times. If it still doesn't work, then we tend to go for inotrops and checking other statuses as well. Most of the patients that we see, they're septic and whatnot, and in those cases, inotrops help more for us. So that's why I think for us who are working in the ICU, the threshold is a bit less. But as you mentioned more clearly, I think what you mentioned, that is explained more clearly for the whole audience.
Yeah, that's really interesting, Shams, that how practices differ based on where you're seeing the patient. So yeah, that's obviously we do agree that practices will vastly differ whether you're seeing the patient in a pre-community setting or in a like pre-hospital setting, or a hospital setting within the emergency department, or in a base ward, whether the patient is for ICU or not. So it's very, I do agree that things quite differ. One of the other things which ICU physicians and emergency doctor physicians have a benefit of, which often medicine doctors might not, is the use of bedside ultrasound and echo, because it can tell you a lot more. It can give you so much more information. Obviously, I won't go much into it. We are hoping for a workshop from Dr. Suneel about ultrasound and echo, but obviously it's common sense. Like if somebody has ultrasound and echo, you can look at the heart's pumping directly. You can look at the body's blood vessels directly, and you can look at the lungs directly, and then take a decision of whether you can go ahead with more fluids or not, because you're literally looking into the body. But I won't go into details about that, because our whole idea is talking about bedside medicine in the context of Bangladesh, in the medicine world, where we have to deal with whatever resources we have in our hands. But yeah, that's very good. That was a really lovely discussion on circulation. So I'll probably just share this case.
Before you move on, before I forget, just one thing is that, which one ITU consultant told me, just ask if they're awake, just ask the patient, are you thirsty? Apparently,
Exactly.
it's massive than any of your skin tug or any of your examination. If they are thirsty, just give some fluids. So just wanted to complete that there.
Yeah, that's really interesting. That's like traditional medicine. Like go back to the patient, isn't it? Like you can be obsessed about your own ideas, but sometimes the answer may be as simple as coming from the patient. And I often hear, like I often seniors tell that, 90% of the diagnosis lies in the history. So yeah, agree. So kind of moving on to a different case now. It's a 40-year-old man. He's known ITP. ITP is idiopathic thrombocytopenic, immune thrombocytopenic purpura, if I have pronounced it correctly. So he presents to the hospital with sudden onset severe headache followed by unconsciousness. He's immediately brought to the hospital, where he's found to have an irregular respiratory pattern and respiratory rate of 26 per minute. And his oxygen saturations are 84% on air. Examination of the lungs revealed crepitation in the right lung base. Blood pressure is slightly high at 160 by 100. Heart rate is slightly low at 55. GCS is very low at 55. Pupils are mid-dilated and has a very sluggish reaction to light. The temperature is 99. So a youngish man who's presented with sudden severe headache and has been found to be having low GCS, slightly high blood pressure, slightly low heart rate, irregular respiratory pattern and tachypnea, and very hypoxic, and lungs showing the right-sided basal creps. So because we have already discussed about A, we already know the patient's airway is significantly threatened because the GCS is 5, which means they are unable to protect their airway, and they are high risk of tongue fallback causing airway obstruction, but also he's at risk of his airway not being protected from his own saliva. He's at significant risk of aspiration pneumonia. I think aspiration pneumonia, one of the main risks when somebody's GCS is low is that they start aspirating their own secretions. And it can be quite dangerous, more dangerous than what people may think. Yeah. So we're already worried about his airway. I can tell you that we already have read about airway. In terms of breathing, what are the things that worries you about this patient? And we will use this case as an opportunity to learn how to oxygenate a hypoxic patient. So anybody can take the lead, Suneel or Shams?
Yeah, I mean, I think mine will be basics. Then your guys are adding more advanced material, so I can just go away. So hypoxic, we are talking only about B here, yeah?
Mainly B, yeah, because we know A wise the patient is. We will talk about B, but we'll also talk about D a bit. But in terms of B, what are the things that worry you about this patient?
So he has this irregular respiratory pattern. So this could be a chain Stokes to be whatever name they give it. And he's bit tachypnic and his saturations are low. And now his lungs already reveal crepitations in lung bases, so probably he's already aspirated. And so oxygenation wise, I think he we don't see any trauma in him. It's sudden onset. And assuming there is no contraindication and he's not in a C collar or something, we can put him in a slightly head and elevation or a bit of a recovery position, give him 100% non-rebreathing mask, and see if he will, what happens to the SATs, and if unless there is more issue with the A also, simultaneously looking at whether secretions, gurgling and stuff to see if there is anything to suction and things. Once your 100% oxygen through non-rebreather mask, 15 liters is given, we'll see what happens to the oxygen. So if still hypoxic, we are not happy, we can try some airway adjuncts. Sorry, we can adjust the head position. So trying to do your head tilt and chin lift and a bit of a jaw thrust if the tongue is falling back. And if that is also not helping, we can use something called airway adjuncts like your oropharyngeal and nasopharyngeal airway, especially making sure the patient tolerates and doesn't gag and make them more vomiting and prone to aspiration already with this person. But also these interventions can increase your intracranial pressure. So we need to be very careful even before thinking about using adjuncts, and we have to be absolutely sure that that is necessary for the patient and they will tolerate it. So airway adjuncts, we have different, as we mentioned, the oropharyngeal and nasopharyngeal, and rarely, I mean, not rarely, we do go for supraglottic devices, but not in a live breathing patients. And yeah, but because he is very sick. Otherwise, I mean, oxygenation wise, we have different devices like, you start with nasal cannula, go with fixed delivery devices like Venturi masks, or then non-rebreather.
Yeah, that is absolutely correct. I completely agree. Shams, would you like to add anything about this patient?
Yeah, Dr. Suneel mentioned very nicely all the steps. Absolutely, I would like to secure the airway first with an oropharyngeal or nasopharyngeal airway. And then in breathing, I would like, as he mentioned, with a non-rebreather mask, 100% oxygen, I would like to start that as well. And just additionally, I would like to, see as I've seen, but in just a neurological examination, additionally, I would like to check any signs of meningeal irritation and the frontal. I would like to see the frontal as well. And vocal neurology. That's extra that I would like to see.
Brilliant. Yeah, so I'll just add my take on this as well. So for somebody who presents with a sudden onset severe headache, where you have an irregular respiratory pattern and you have very high respirate, so, when I was talking about B, I was talking about two main concerns. One is there a risk of ventilation, ventilatory or respiratory arrest? And the second is there a risk of hypoxia, or is there a hypoxia? So I think for this patient, this is a beautiful example of, sorry, not a beautiful example, but this is a very good example of a patient who has both these breathing abnormalities. I think the patient is at risk of impending respiratory arrest, and the patient is also hypoxic as well. Regarding the impending respiratory arrest, the main question is, can I immediately reverse it? If I can, for example, by naloxone for an opioid overdose or hypoglycemia treatment, then probably I can wait. If it seems to be a more persistent problem, in this case, for example, there's a likelihood this patient may have bled from his intracranially, then I need to intubate the patient. I can do whatever I can. Like if the patient is still for intubation, I'll have a lot of time to do a lot more things. But if the patient has a respiratory arrest in the next 30 minutes, which is already at risk of because the respiratory rate is irregular, then I need to immediately call my critical care colleagues regarding the need for intubation. And secondly, he has already the hypoxia. So when somebody is hypoxic, I first go back to A, like Suneel said, to see whether the hypoxia can be improved with airway optimization. So obviously, if somebody's hypoxic, you would want to make sure they're not hypoxic because they cannot get enough air into their lungs because of airway blockage. So you would want to make sure there is no tongue fallback. you would want to make sure that you've done a head-up chin lift maneuver if there is no contraindication. If there is no contraindication, you would want to make sure that there is no tongue fallback. Yeah, but your assessment will tell you, isn't it? If somebody's got hypoxia due to airway blockage, they will have gurgling sounds, they will have upper airway transmitted sounds and stuff like that. And it will improve as soon as you do a head-up chin lift maneuver. However, if airway is not a problem, then obviously with breathing, I need to deal with the hypoxia. Dealing with the hypoxia, 84% air, I will put them straight on 15 liters non-rebreathing mask based on common facilities we have in Bangladesh. So I'll put them on 15 liters non-rebreathing mask and see what their oxygen saturations get. I already know why they're hypoxic, because the lungs examination has told me there is a right lung basal crepitation, which until and otherwise proves probably is aspiration pneumonia in this patient's context. Yeah, I'll try to get a chest X-ray, a portable one if possible, but I have to give 15 liters and see if it's working or not. If it isn't, then I need to go higher. So beyond 15 liter non-rebreathing mask, I should be discussing with critical care colleagues whether they want to first try the patient on high flow or even CPAP, whether it's safe or not. Obviously, with an intracranial hemorrhage, it may be dangerous, or whether they want to intubate the patient and oxygenate that way. But I think the important thing is, in any hypoxic patient, do not titrate up, rather titrate down. Start at the highest level, which is 15 liters non-rebreathing, and then go higher if needed, or go lower if needed. Yeah. So that is what I would do. Going to D, the patient has got probably an intracranial event. The GCS is slightly low, so his airway is already threatened. Again, another reason why he may need to be intubated, because this doesn't look like a readily reversible cause. His blood pressure is high, his heart rate is low, he's got mid-dilated pupils, irregular respiratory pattern. All this in D suggests that he has got raised intracranial pressure. And from that raised intracranial pressure, he is now having brainstem dysfunction. So again, a D will tell us whether there is any structural brain problem. A D will tell us whether there is a meningism. But I think one of the important things of D is to ensure that there is no raised intracranial pressure. This patient has raised intracranial pressure. So this patient is really, really, really unwell. The chances of mortality is really, really, really high. But the least we as doctors will need to do before it's too late is to protect his airway, protect him from further aspiration, treat him from type 1 respiratory failure, intubate him probably, and addressing why he has a raised intracranial pressure and taking urgent medical and probably neurosurgical measures to lower his raised ICP. Is that something you guys would agree?
I'll wait for Shams to say, because
yes, absolutely. Like in this type of cases, what we usually do in the ICU is that as we are the critical care team, so like after assessing, if it is like even after giving the oxygen, we see the irregular respiratory pattern, it is still not improved, like after 1 hour or after 30 minutes to 1 hour, and we do regular ABGs like in 20 minutes interval, and if we tend to see if there is any carbon dioxide retention going on, we tend to intubate the patient first, and then once we intubate the patients, we know the airway is secure, and then we tend to go for the imaging to see what's actually the problem, the intracranial hemorrhage or whatnot, and then that's what we actually approach these cases.
But Shams, I would be a bit concerned about this patient in particular, because the patient has got a intracranial problem which is irreversible and has already lost his airway. Yeah, and also has impending respiratory arrest. In this case, probably I would be concerned if he's still for intubation, I would be probably concerned if we are not intubating him straight away. This is like my personal opinion.
Yeah, maybe. Actually, as I mentioned, probably in the normal ICUs, they will do that. They say the threshold for intubating a patient, it's very less, like as you mentioned. But there at the same point where I work is the COVID ICU, and in COVID ICU the threshold is very high for intubating a patient, because we know once, even for these cases, if the patient is COVID and we intubate the patients, then the chances of extubation it is very less, like because most of these patients have damaged lung as well. So in our cases, the practice differs a bit. But yeah, I absolutely agree with you. In the normal ICUs, non-COVID setting, we would intubate the patient first rather than waiting, because as the airway is in danger.
Yeah, and this patient especially has an intracranial sounding lesion, isn't it? Like it's a sudden onset severe headache. Somebody has ITP, so this is probably an intracranial event. Sorry. So I think like personally on this patient, I would probably my side push towards an intubation, but obviously it will depend on what the critical care team say. Suneel, you were saying something.
So because this is the situation I find myself most of the times every day in my work. So what happens is, so we know there is two types of things. One is a catastrophic bleeding, which neurosurgery or people are going to say that no, nothing, because the GCS is quite low. He's already chain stroking. We are already seeing something called Cushing reflex. I mean, I'm going into case specifics because we are into the critical, the point about intubation versus getting a CT first. Depending on where you work and how far is your CT room from the place you are with this patient. Like if you need to shift a patient somewhere to get a CT, obviously it's not going anywhere without securing the airway. But if it is in your next door and CT literally takes 5 minutes, so the critical care team are going to come and they're going to do all the measures we talked about earlier, and they are going to get a CT in the next 10 minutes and then come back and then make a decision after seeing that, what is happening there. It doesn't mean that it's not going to change what they are thinking. I mean, it's a 40-year-old, there are some more issues in this point, but if it is something of very catastrophic bleeding, they are still going to do those measures until a neurosurgery opinion is sought that they are going to operate on this.
Yeah, that is really interesting, Sunil. So I think what you said makes sense, because I can completely see if the patient is not for a neurosurgical intervention, and if the bleeding is catastrophic, it probably means the patient is gonna die regardless of what we do.
So the intubation is not going to serve any purpose. And so the critical care will need to have a definitive plan to actually do that. I think the practice is different in different places because...
No, but I completely agree that obviously ethically, if an intubation won't save the patient and the patient is definitely going to die, something we doctors need to decide. And if the patient is definitely going to die, then an intubation should not be done. I do agree. I agree with this. Yeah, because obviously, if it's a catastrophic bleeding and if the patient is imminently dying, God has only given doctors some powers, not all, isn't it? Yeah. Interesting. So I think this case is really interesting because it not only teaches us about airway, it not only teaches about breathing problems, but it also teaches us the importance of D especially in unconscious patients, because unconscious or altered consciousness patients can have such a wide variety of conditions. From simple constipation and urinary retention causing delirium in elderly patients leading to altered consciousness to something as catastrophic as an intracranial bleed, the spectrum can be so wide. So I think as physicians, it is our responsibility to do a proper ABCDE assessment, and in D, answer whether the patient's lowered altered consciousness state is due to a metabolic or a non-intracranial problem, or is it due to an intracranial problem? If it's due to a non-intracranial problem, then either you don't need to do a CT head at all, or you only will do a CT head if you don't have any obvious answer. But if it's from your initial ABCDE, especially from D, if it looks like an intracranial problem, then you need to immediately stabilize the patient and probably rush to a CT head within the next 10 minutes. So how quickly and whether you do CT at all will depend on a very good D, disability assessment. So again, I would probably go through the D, then things we check. Yeah, in D. So look at the patient's, whether there's any focal asymmetry. Look at the patient's blood, start with blood glucose. That's my opinion. Always check the blood glucose, because low blood glucose is the commonest cause for a low GCS. Look at lateralizing sign. Look at their pupils. Look at their planters. cranial nerve, GCS, meningism. This patient already has a lot of features in these, and the GCS is low, the pupils are mid-dilated, the respiratory pattern is irregular. Yeah, this until otherwise proves that there is brainstem dysfunction. And in this context of a severe headache, this is probably due to a like massive intracranial hemorrhage. It may be a subarachnoid hemorrhage, it may be an intracerebral hemorrhage, but the whole idea is rushing towards is that important CT head, which will alter your management plan. Okay, that's interesting. So I'll just run past another quick case. Just one sec.
It must be very tiring for Dr. Suneel after the night shift. You're still sitting with us.
We are very grateful. So I've got a
bit muddled. I'm not giving detailed explanations like you both.
No, it's okay. It's just we're very grateful that you're still with us after your night shift.
Okay, so the next thing I would probably want you guys to touch, because this is quite useful, is this thing. So in terms of when we are giving people oxygen, what are the things which we can use as oxygenation measures for the normal bedside ward doctors? So I'm not talking about high flow. We all know that if 15 liters non-rebreathing mask fails, then we have as options high flow, CPAP, or even intubation and BiPAP and all these things. But for normal oxygenation, what are the things we can use? So this is like the, this is like the 15 liters non-rebreathing mask we can give, isn't it?
Yeah, we like tend to use the, like, as you use as well, like the nasal cannula, then the face mask, then the non-rebreather mask. And after this, like the Venturi mask, as you showed in the previous picture with the different colors. Yeah. But the Venturi mask, we tend to use it less in the ICU. We straight actually go from the non-rebreather mask, we tend to go to the high flow nasal cannula.
No, fair enough. So one thing I would probably say from my side is, if anybody's hypoxic, I always start at the highest level, 15 liters non-rebreathing mask, regardless of whether they have history of COPD or regardless of what. Then once I've started the 15-liter non-rebreathing mask and I've done the ABCD assessment, by the time I have done an ABCD assessment, remember, E is for everything else. So in E, you're doing a lot of other things. You're taking a history as well. You're looking at past records as part of your E, I think. So by the time I've done my ABCD assessment, if I think the patient has got history of carbon dioxide retention or long-standing COPD, then I would probably switch my target to 88 to 92. And then I can switch to different oxygen methods. But till I have that information, I'll always start a hypoxic patient on 15 liters non-rebreathing mask. And the whole idea is start high and titrate low rather than start low and titrating higher up. Yeah. So I think once I want to titrate the patient from a 15 liter down, I have face masks, from which I can, a simple face mask, which I can give up to around 5 to 6 liters of oxygen. Yeah. And then I have the simple nasal cannula, which I can give around 2 to 4 liter per minute oxygen. So when do I start using Venturi mask? Suneel, do you want to kind of take us through when you would want to use a Venturi mask in particular?
So, just what I heard about this, previously we were very obsessed about something called PF ratio. I think the definition of your ALI and your ARDS were based on PF ratio in the past. At that time, we were so obsessed about knowing exact percentage of FiO2 that we are giving to the patient.
Yeah.
So that we can calculate that, and we used to grade and we used to see the improvement and things based on exactly our gases. So I think we are moving much away from that, because ARDS definition has changed. And we are happy. Actually, no one's doing ABG for looking at oxygen levels. I think at least pre-COVID, even in the COVID stage, we are doing gas just to establish baseline, and we are not actually chasing off your PO2. We are actually going more towards SO2 or or SpO2 rather than if they're saturating well, you don't have to worry about your PO2 levels. So Venturi, I think that's one more reason that, and also it's the aerosols are coming out. That's one more reason we stopped using here. But I think Venturi is very good in a way that I know exactly what I'm giving. If I give 5 liters through my face mask, exactly I have no idea how much oxygen I'm giving. You cannot put that 5 liters as your, calculating your FiO2 for the patient.
Mm-hmm.
So the fixed rate delivery is what is important, like highlights this Venturi mask usage.
Exactly.
And
So yeah.
exactly sorry, I was just broken with something else. My phone was ringing. So Venturi mask, I think, especially in your COPD patients, if you end up giving more than 2 to 3 liters for a long time on the nasal cannula, it's very irritating and it's not very, what you call, some people might not like it.
Mm-hmm.
So at that time, if you're giving like continuously, if you want to know exactly how much oxygen you give and so that you don't want to exceed it, so going for Venturi will be still a very good idea. Is what I use most commonly, at least in our practice.
Okay. Yeah, that is completely, like, that makes sense. That makes a lot of sense. So I will add my take on this as well. So when somebody, especially for COPD patients, when somebody has history of long-standing COPD or has a history of carbon dioxide retention in the past, we need to be very strictly maintaining oxygen saturations between 88 to 92, isn't it? Because any oxygen saturation below 88 will be detrimental because of hypoxia. Any oxygen saturation above 92% puts them at risk of retaining carbon dioxide again. Yeah. So, but that's a very narrow range, 88 to 92, very, very narrow range, which means we have to be very consistent. I think the important word is consistent. We have to be very consistent with the amount of oxygen we are giving these patients. To maintain oxygen saturations in such a narrow range, the oxygen cannot be too high, the oxygen cannot be too low. I'm talking about the oxygen we are giving them. So the problem with with agents like a non-rebreathing mask or a simple face mask or a nasal cannula, these are three things which are used for type 1 respiratory failure. The problem with these three masks is these are called fixed rate devices or fixed flow devices, but they're not called fixed percentage devices or fixed performance devices, which means they will always give you oxygen at a particular rate. For example, 2 liter or 4 liter or 6 liter or 8 liter or 10 liter, but the percentage of oxygen they're giving you will vary. And it will vary depending on your respiratory rate. For example, if you're taking a 15 liter per minute oxygen, 15 liters per minute oxygen through the non-rebreathing mask, the amount of oxygen you're getting can vary widely. It can be as low as 40%, or it can be as high as 85%, or it can be as high as 60%. Who knows? It will vary depending on your respiratory rate. If you're breathing too rapidly, then you are extracting less oxygen. So the percentage of oxygen the same device gives you will fall. If your breathing is slower, then you will extract more oxygen. So the percentage of oxygen you're getting from that same very device will get higher. And because in conditions like, say, exacerbation of COPD and other breathless conditions, your respiratory rate will vary hour by hour. For example, your respiratory rate might get better with salbutamol in nebulization, or it can get better eventually, or it can worsen. Because your respiratory rate will vary, if you were to maintain a strict oxygen saturation target of 80 to 92, you cannot take the risk of fixed rate devices like a simple face mask or a nasal cannula or a non-rebreather mask. Because like I said, with your respiratory rate varying, the amount of oxygen you're going to get from this will vary, even though the rate will stay the same. That is where the Venturi mask becomes so important, because the Venturi masks are called fixed percentage devices, meaning that if you use a particular color, and use a particular rate, at that rate, regardless of your respiratory rate, you will always get the same percentage of oxygen. So what we normally do in a in Venturi device is we connect a mask like this with a particular color. Which color we want to use depends on how much oxygen we want to give the patient and how. So if we say we have decided the patient can maintain an oxygen saturation of 88 to 92 with 6 liters of oxygen, then you'll use the orange color. You'll connect it with this mask, and you have to give the patient 6 liters oxygen, and the patient will then persistently get 31% oxygen. Regardless of, sorry, regardless of the patient's respiratory rate, they will always get 31% oxygen as long as you are connecting it with 6 liters of oxygen. If you then go to see that you need 40% oxygen, you'll need to connect it with a red color device and give the patients 10-liter oxygen. But you'll always get that 40% oxygen. Sorry, I've had a coughing bout. Is that something you guys agree, like regarding the usefulness of Venturi? Mainly for those doctors who are bedside in a junior, like in a bedside setting, when to use Venturi and what's the usefulness?
Yeah, that's
use of this in bound shifts. That's Dr. Suneel can actually tell us like how much is it used in their hospitals.
Yeah, so where I work, the nurses are very well trained where they recognize how much oxygen is needed to maintain oxygen to 80 to 92. Once they have realized that a patient will need 20% oxygen, then they'll use white colored device and connect it with 4 liter. The important thing to remember is if you want to use a 28% oxygen device, you have to use not only the white one, but you also have to connect it with 4 liter oxygen. So Venturi mask, the 3 things to remember: what color you want to use, what percentage you want to use, and for that, how much oxygen you need to give through that device. Because if you're using a white color device, you'll not get a 20, it will go wrong when you start giving 6 liters oxygen through that white color device. No, you can only use 4 liters. The moment you decide you need to give 8 liters, then you need to switch to a yellow color and give through 8 liters. So that's, I just thought we would use this opportunity to discuss a bit about the Venturi device. Now we've studied about A, B, C, D. Now E is for everything else. Every other thing. So I'll probably use this opportunity to very, very quickly discuss 2 cases where the importance of E can be assessed. So we have already discussed this case, haven't we? So, when we talked about this elderly patient, a 55-year-old patient who had presented with 1 month history of weakness, lethargy, tiredness, and was found to be in circulatory dysfunction, the case we discussed earlier, who was also hypothermic and hypoglycemic, what we also need to realize is by the time we've done a proper E assessment, we have already looked at the skin. And for somebody who has got generalized blackening of the skin and mucous membranes, after ABCD assessment, you have not only realized the patient is in shock, but the patient has a adrenal. Exactly. So one example of how a proper ABCD assessment, when you're looking at the skin, can give you a diagnosis as well. So if we talk about this patient, if you talk about this patient, a 60-year-old man who has a stroke, who's been admitted in the hospital, being treated for stroke, suddenly becomes breathless and tachypneic and hypoxic with a respiratory rate of 30, oxygen saturation is quite low at 80%, but the lungs is clear. The blood pressure is slightly low and he's tachycardic and you don't know what's going on. And then you examine the abdomen, which you find soft. You examine the legs, but you notice that there's an asymmetric leg swelling involving the right side and slightly tender compared to the left. What would your diagnosis be? Yeah, Shams, would you agree?
Yeah, this looks like it looks like DVT and respiratory with pulmonary embolism.
Exactly. So I think this is an example of how a proper E assessment can tell you what's going on in the background, isn't it? Because you then get to know that because you've examined the legs and you have a patient who's hypoxic for no reason because the lungs is clear, but he is hypoxic, and then you notice the legs which has got asymmetric swelling. So it does tell you that it's possible that this patient has got a DVT, which he's at risk of because he has a stroke, and stroke patients don't get LMWH and they are bedridden. So a DVT can easily occur, and from a DVT, a PE can occur as well. So I'm going to move you to another quick case. Just one second. There you go. So a 20-year-old female is brought to the hospital via the ambulance after having a sudden onset shortness of breath associated with extreme restlessness and agitation. She was completely normal even a few hours back. So we have no other medical background. She has been completely fit and well all her life. So when we look at her airway, she's got decreased air entry bilaterally and she's got stridor. We listen to her lungs and she's got widespread bronchi, oxygen saturations of 60% only, and very tachypnic at 50 per minute. We look at the circulatory status. She's peripherally well perfused, but she's very tachycardic. Her blood pressure is quite low. Her capillary filling time is just on the borderline. Her JVP is not raised. She doesn't have any evidence of pulmonary edema. Her ECG is sinus, and the nurse immediately takes some samples for blood and does a cannula. It's important to know and make sure that as soon as we recognize stridor, we should be calling the the emergency team. Yeah, because I'm not saying she needs intubation, but she may need, so that we already have them in hand. So the anesthetist, the critical care team, the MET, the medical emergency team. So I'll probably put a code blue for this lady. With B, as soon as I recognize that she's hypoxic, I'll start from 15 liters non-rebreathing mask, isn't it? And I will make sure, because there's a lot of bronchi, sometimes you can immediately take steps to correct what is leading to the hypoxia. So if there is excessive secretion, you can do some physiotherapy at the same time. If there is a widespread bronchi, you can try for some nebulization. So I'll probably tell the nurses to get some nebulization immediately. Blood pressure is low, so I've cut the cannula. I've put her on fluid challenges. Yeah, and I've taken emergency bloods as well, and I'm waiting for a blood gas. D, she's agitated, but she's got a normal GCS. I wouldn't want to miss out on a hypoglycemia, but her blood sugar is okay. Her E is about everything else. So the abdomen is soft, the legs are soft, and the general skin survey shows widespread urticarial rash over her body. The temperature, which is checked in E, is normal. So how does the ABCDE assessment, and especially E, tell us about what's wrong with the patient?
So just before we answer this question, Latif, so this is one of your classical example. Sorry to bring ALS again into this, because this is the classical example used in ALS, how we use the classical teaching that don't proceed to B until A is sorted doesn't work for this.
Yeah.
Don't proceed to C until your B is sorted, but this A and B will never be sorted until you actually simultaneously manipulate C and E in this patient.
Yeah, that's really interesting. Would you like to walk us through the case then? What?
Yeah, I mean, so this is because it's an exam type question. Yeah, we clearly mentioned widespread urticarial rash with the V's, and yeah, it's a classical hypotensive, tachycardic, stridor. So it's a classical anaphylaxis, a known cause, probably don't know what she had, an insect bite or she ate something before. So until we give adrenaline, yeah, literally we will be stuck with about airway, whether intubation, doing different things in this patient, isn't it? So this is very good that you added this case, and this is the classical example of how ABCD sometimes needs to go simultaneously and don't have to get fixated at some point in your whole of your assessment.
Exactly. So I think the E is in somebody who, if we don't look at E, it can be anything. It can be an asthma attack. We never knew that she has an asthma, isn't it? But I think the clinching factor in this case would be the widespread urticarial rash that she's having. So so normally I completely agree with you, Suneel. Practically in an emergency setting, it should never be one doctor seeing a patient. It should be a team. It should be a leader. It should be 2 or 3 doctors. It should be 1 or 2 nurses, 1 or 2 healthcare assistants or ward boys. It's all on the patient.
In an ideal world.
In an ideal world, exactly. But if you do have that ideal setting, for example, if you're in a relaxed day where there's not many patients and you then suddenly have this unwell patient walking through the door and you are all free to manage this patient, then obviously you should be doing all those things together, doing the cannula while somebody's taking the airway. Yeah. So that everything can be done at the same time. So, but I think the leader is important. If there should be a team leader who's keeping an eye on all the vitals together, so that because if somebody's doing cannula, they won't be equating it with the airway because somebody else is doing that airway. So I think there has to be a leader who's equating all the information given to him by the doctors who are looking after the patient, and then it's that leader who takes a decision what happens next. Yeah. Or if you want to switch the flow from A to E rather than otherwise, like other way around, the leader can take the decision. And obviously, you will have to take this decision in special cases like this cases where the importance is adrenaline, because even though there's stridor, you might still not need to intubate the patient if you can just reverse the laryngeal edema with some what do you call that, adrenaline. On the other hand, if the laryngeal edema is so severe, you might even need to put an emergency cricothyroidotomy. Sometimes, I'm not saying this case, but in sometimes the laryngeal obstruction may be severe that intubation doesn't work. So but I think it's important to realize that the E is for everything else. So in a very unwell patient, what are the things we look in E? So I've jokingly said E is for everything else. So in the traditional world, they used to say E is for exposure, but in my opinion, E should be for everything else. So you look at the temperature, you look at whether the patient is anemic, whether the patient is jaundiced, what's the patient's urine output, is there any flapping tremor, a general skin and joint survey, yeah. You look at the legs, whether there's any DVT, but also a very good look at the abdomen. A lot, Suneel, I'm sure you're an emergency department doctor, a lot of the unwell patients often present because something horrendously going wrong in their abdomen. Like sometimes abdomen, it's such a magic, we used to call it the magic box. Sometimes there may be no abdominal complaints at all. Even believe me, yesterday, there was a patient in a medical ward who came in with reduced oral intake and just tiredness and had a chest x-ray just for an infection screen because the CRP was high. And the chest x-ray showed perforation of the abdomen. So the abdomen has always like mesmerized me. It's such a magic box. It can present in such a like weird ways. So I once got a patient who had a syncope, and then as part of the an emergency call was put out, and I, as part of the ABCDE, palpated her abdomen, and it was very rigid. And then the lactate came back at an 8, and the history was just diarrhea, not even any abdominal pain. And then it turned out to be a perforation. So in E, it's very important to examine the abdomen, and a traditional medical school has taught us to examine for organomegaly or any any masses. But I think in an emergency setting, the most important thing you want to get, most important information you want to get from the abdomen is whether there is any peritonism and whether there's any ascites. Yeah. And I think also, is there any urinary retention, palpable bladder? So this, I think, is more important in an emergency setting. So surgical abdomen would mean probably guarding, probably rebound tenderness, probably any severe tenderness in any particular point, absent bowel sounds. Yep. So look at the abdomen, look at the temperature, do a general skin and joint survey, look at whether the patient is anemic, whether the patient is jaundiced, whether the patient what's the urine output, whether there's any flapping tremor. But E, I think, is just puts a gloss to the makeup, I would say. Probably, just after you've done really hard work with your ABCD assessment, E puts it all together. I also like to include in E a brief history from the patient and their attendant as well, because that also helps complete the picture. What were their medical conditions? What is their presenting complaint? What drugs were they on, and things like that. Because a brief history, a very short history, it shouldn't take more than 5 minutes, puts the whole ABCD makes the whole ABCD a perfect assessment. Would you like to add anything to the E part, Shams or Suneel?
Yeah, that's perfect.
Great.
Like, just I would like to add, like in COVID patients, as we deal, usually we tend to have very, what is a high uh, suspicion of any respiratory problems or any, suppose any DVT or like that. But what I tend to practice while receiving COVID patients in the ICU, that as you mentioned in the E part, I tend to do a good abdomen examination, like at least I see any localized tenderness is there and any bowel sound is there, and I just ask the patient if they're awake that did you pass any bowel, okay, like any stool in the recent times. So in around 20 to 30% of the patients, we tend to find that COVID patients, they present with either pancreatitis or any mesenteric ischemia, and then so uh, I found a lot of patients in the COVID setting that they either they had underlying any mesenteric ischemia or any pancreatitis. So without like just a quick abdominal assessment, I think we could have easily missed this, and also we can easily lose patients because of this. Because most of the time the patients do not complain anything regarding the abdomen. They're like absolutely fine. They're just having some respiratory distress. So yeah.
Yeah, it's amazing how COVID keeps on surprising us. COVID is like, it's so unpredictable. And
It's like the new world's PE or dissection, man.
yeah, exactly. It's just weird, man. I like COVID. It just keeps on surprising us. So the other things which you would probably need to incorporate, you need to be innovative about E as well. For example, if somebody is delirium and if somebody is elderly, you would always want to do a rectal examination to make sure the patient is not constipated and loaded distally with stool. Yeah, because this is a simple constipation can trigger a delirium, and you then don't have to do an MRI on brain of somebody who's just delirious because he's constipated, and you don't know about it because you didn't do a PR. If somebody presents with a hypovolemic shock and you have no idea why the patient is in shock, but you don't do a PR where you realize that the patient is actually having gross melena, then you might never know about it. So I think sometimes we need to be innovative about E, what we do in E, because it can be so varied. If somebody's delirium, I would probably always check the post-void bladder scan to make sure the patient is not in urinary retention. If somebody has AKI, I will always do a post-void bladder scan. This is part of my E. So E is also about innovation. So yeah, I think that was quite useful. So I'll just probably just summarize. I found the last few last 2 hours very engaging. Suneel and Shams, thank you so much for your effort, for your presence. Really, I don't know about you two, but I really enjoyed the discussion over the last 2 hours. So probably it's almost over. So I'll probably take the opportunity to summarize the cases, summarize what we've discussed so far. Yeah.
No one has any questions at all.
We invited questions to the chat box, but I think the participants were just glued to what you and Shams were saying. So for all the participants who are here with us, please feel free to ask us questions either now, or you can also pop up questions in our School of Acute Medicine Facebook page. And we will, if you have any questions, any difficulties with understanding what we have discussed so far, please feel free to get back to us. What we have done is, from our page, we have also shared the ABCDE management, a kind of a short written chapter. So you can read that as well. It's not exactly short, it's 20 pages, but that's quite informative. So you can have a read of that chapter as well. And please feel free to ask us any questions either now or through our Facebook page, yeah? So in terms of summarizing, because we just have only 5 minutes left. So when we see a patient who's unwell, we start with, we obviously look at A. In A, the main two things we do is we ask if the patient has got airway obstruction from maybe tongue fallback or laryngeal edema or things like that. Or second, at the same time, we also ask the question, is the patient able to protect their airway from aspiration? So I think these are the two main questions. Is there airway block? Does the patient have risk of aspiration? If the patient doesn't have a block, doesn't have an aspiration, we then need to ask, does the patient have a risk of having this in the next few hours? And then you need to take steps to correct it. If the patient already has airway block, you need to relieve that block. If it's due to tongue fallback, things like head up chin lift can help. Things like oropharyngeal airway or nasopharyngeal airway can help. Yeah. If the patient has aspiration already, has had aspiration, it means the patient has already lost his airway. Then depending on why the patient has lost his airway and whether it's reversible or not, you need to speak to the critical care department regarding whether it is needed and appropriate to intubate the patient. Sometimes basic measures like putting the patient in proper position or suctioning excess secretions can reduce the risk of aspiration, but we just need to be mindful of it. If somebody has a low GCS but doesn't yet have a tongue fallback, doesn't yet have a low doesn't yet have an aspiration, it might still be worthwhile looking at why the GCS is low, whether it's immediately improvable or not, and if not, whether intubation will be needed preemptively. Going to B, it's the main two things in B would be two questions again. What's the patient's, what is there any risk of impending respiratory arrest, and what is the oxygen state? If there is a risk of impending respiratory arrest, and that is due to a reason which is not immediately correctable, we need to speak to critical care department regarding need for urgent intubation and ventilation. If the patient has got a impending respiratory arrest due to a reversible cause, then you need to treat that urgently, like naloxone for opioid, treating hypoglycemia, treating severe hyponatremia, and things like that. Okay. The next question is the patient hypoxic? If the patient is hypoxic, you need to start at the highest 15-liter non-rebreathing mask and then either titrate down or titrate up as needed. Titrating down may involve one of face mask, nasal cannula, or even venturi mask if you want to stick to a very strict oxygen saturation target. Titrating up may mean one of high flow, CPAP or BiPAP, or even intubation. Speak to the critical care team. Yeah. And also, in hypoxia, you not only need to treat the hypoxia, but you need to, if there is any immediate reason why the patient has hypoxic, for example, bronchospasm due to asthma, bronchospasm due to anaphylaxis, you can immediately correct that as well. Nebulizations, if adrenaline for anaphylaxis and stuff like that. If there is a lot of profuse mucus plugging, you can immediately get the physiotherapy team to try to help with the mucus clearance, isn't it? So once you've sorted the, as you're sorting the B, somebody needs to look at the C. So C is about circulation. So again, you look at the most important thing will be deciding the patient's circulatory status. So you look at the heart rate, you look at the blood pressure, you look at the peripheral temperatures, you look at the capillary refilling time, you look at the precordium, you look at the JVP, you examine the lungs very quickly to make sure there is no pulmonary edema, you look at the bedside ECG, and you look at the patient's hydration status. Yeah. Then you don't wait to treat things. If you think somebody's got a low blood pressure and you would probably consider doing a fluid challenge, you need to make sure there's cannula in, you need to take some emergency bloods. All this fall into C. Yeah. If there's any fatal arrhythmia, you might need to treat it. Yeah. Straight away. So it's about a quick circulatory assessment, but it's also about immediate management at the same time. In terms of D, the most important four things would be checking the blood glucose, which never should be forgotten about in an ABCDE assessment. You should look for any obvious asymmetry, focal asymmetry, which suggests an intracranial space occupying or an intracranial structural cause. You need to look for meningism. And lastly, you need to look for any raised intracranial pressure. So you look for obvious asymmetry in the way they're moving, obvious asymmetry in their facial appearance, obvious asymmetry in the pupil size and the reaction to light, obvious asymmetry in the facial appearance and the way the eyeballs are looking. You also look at the planters, you look for meningism, you look at the GCS, and yeah. And lastly, you might want to come back and do a fundoscopy. And finally, E, like I said, is for everything else. Make sure you look at the abdomen very carefully. Make sure you look at the legs for any DVT. Make sure you do a very good skin and joint survey. Look for signs of anemia, look for signs of jaundice. What's the urine output? In delirious patients, consider doing a rectal examination to look for constipation. In AKI patient, a post-void bladder scan is very important. It is important to state that a simple manual palpable examination for palpable bladder is not sensitive enough. So if you think there's a chance of urinary retention, ideally, but it's not always possible, to do a bedside bladder scan. So yeah, so Suneel has summarized us really well in the chat box as well. Thank you so much, Suneel. And I think I think from Access live stream, we also have the link for the page about like the page School of Acute Medicine. So uh, do visit us in this page as well. And I would probably last, because we have you, Sunil, with us today. Would you want to make us go through your page about bedside ultrasound that you run?
It's not so much running now, man, because what's happening with the issues. But like what I said was, I think that's a very, 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 very useful skill. Like, you know how we both are actually crazy about it, and we know what it has done changes to for the patient care, exactly like from what we have done. So yeah, just guys, this is a channel. I think if I started it with a lot of enthusiasm and lots of passion and stuff, but then recently there are certain changes in the workplace that I couldn't do more of it. But I hope things change in the coming months and I can rerun it again. But I wanted to start with, you know, setting up the machine to the basics and go with different parts of the ultrasound, including echo and focus. But yeah, it is halted for now. But yeah, you can see lots of interesting stuff in there. Hopefully I can get back to that, and then yeah.
Yeah. Just for the reference, what is it? How do how can the viewers access it? Is it, what is
It's
it called?
on the YouTube. It's called ER Sono. It's called Emergency Room Sonography. It is with the name of ER Sono, and currently we have, I think, 15 videos, interesting cases, and kind of how to set up your ultrasound machine, and what are the safety indices on that, like how much should be your power level, and what you should be careful when you are scanning a pregnant lady, types of stuff. But there are also some interesting cases.
Are these the videos that you're running from your program ER Sono?
Yeah.
Okay, brilliant. Yeah, for somebody who's interested in bedside ultrasound, Sunil works quite a lot for teaching people about bedside ultrasound and bedside echo. So do keep an eye on this page, and we will hope for more videos from you, Sunil.
And the same group again, same thing on the Facebook with the same name. So where, because I couldn't make videos, I'm doing the short, small teaching articles and journal stuff, only ultrasound related mostly. But
Yeah,
yeah, I hope we will do more stuff with ultrasound based in here.
it's just the page Facebook, ER Sono. Yeah,
That's it.
brilliant. Okay, thank you so much. We did quite enjoy your presence, Sunil. And Shams, thank you so much for enlightening us about the COVID world and what are the things you do in this COVID climate. I think this is probably the most important thing we're dealing with very often now, like in this pandemic. So it was really very useful to have your expertise, especially from a critical care point of view and from the world of COVID, like world of COVID, which keeps on surprising us. So thank you guys. I really enjoyed your presence over the last 2 hours. Hopefully for everyone else, do keep an eye on our page. We are targeting for regular, if possible, once a week webinars on different topics related to acute medicine. Our next topic will be on how you manage a patient with a hemodynamic instability or shock. So we do plan to get back to that webinar within the next week or so. Thank you so much.
Thanks, man. See
Thank
you.
you. And Mr. Farhan Chaudhary, are you here with us?
Yes, sir.
Okay, thank you so much for coordinating the event. Mr. Farhan Chaudhary is from Access Medical School. He is our technical manager. He helps us run these webinars, and he does a fantastic job in terms of designing this webinar. So a massive gratefulness to you as well, Mr. Farhan.
Thank you, sir. Grateful.
Okay, yeah, thank you so much. Yeah, take care, everybody.
Assalamu alaikum.